My name is Dr. Donald Warne. I'm the chair of the Department of Public Health at North Dakota State University, and I was also on the planning committee for this conference. Very honored to be a part of these important discussions. I'll provide an overview of some of my perspectives on social determinants of health, and then I'll have my good friend Olivia Roanhorse discuss what they're doing through the Notah Begay III Foundation. So to get started, we'll each speak for about 15 minutes, like I said, and then we'll plan to have about 10 to 15 minutes for Q&A, and we're already at 11:20, so we're getting started just a little bit late. Just very quickly, I wanted to talk a little bit about traditional perspectives on public health. And in the Lakota way and the Dakota way, we never had a written language until recent times. And historically, what we would do is have stories to tell about our lessons and things that are important to our culture and ways of knowing. And there's a traditional story in the Northern Plains about three sisters walking along a river. And as they're walking along the river, they see babies and young children in the water struggling to stay afloat. And the first sister jumps in and says, "This is a crisis. This is an emergency. We need to get the babies out of the water right now." The second sister says, "No, we need to teach them how to swim so they can survive while they are in the water." And the third sister just keeps walking upstream. And the other two say, "Where are you going? Why aren't you helping us?" And she says, "I'm going to find out who's putting these babies in the water, and I'm going to stop them." That's public health. That's working further upstream. And when we think about what we do in medicine and in public health, we spend a lot of time and energy on treating complications of diseases like diabetes, and relatively little time focusing on the root causes of some of our challenges. So I'm from a small town called Kyle, South Dakota, on the Pine Ridge Indian Reservation. The traditional name of Kyle is Pchejutahaka, which means medicine root. And in this region, we have a lot of our traditional healers who are from this area. And in Kyle, it is a food desert. I won't spend too much time on this because I know many of you are familiar with food deserts and certainly our reservation communities. But here at the cafe in Kyle, I think what they've learned is you can bread and deep fry just about anything and serve it for lunch. Across the street from the cafe is the gas station, which also doubles as a grocery store. So you can imagine the types of foods that are available. The nearest supermarket in Rapid City is 100 miles away. So 200-mile round trip to get to the nearest supermarket. One of the outcomes, of course, is poor health status and poor outcomes related to things like diabetes. This is one of my relatives with an amputation. And as we all know, this is one of the complications of diabetes. And in my community, there's a program that will build you a ramp if you're in a wheelchair. And that's wonderful, so people can get into their homes. But wouldn't it make more sense if we invested in healthy food in the first place? We wait until there's an amputation, then we invest in the person's needs. So it really is reversed from where it should be. And just very briefly, some of our staggering disparities. Average age at death in North Dakota is 77.4 years for the white population and 56.6 years for American Indians. So in many ways, this is third world health conditions. And I remind my colleagues in public health academics that you don't have to cross an ocean to find third world health conditions. It's right here in our communities. And we're familiar with the terrible diabetes disparities in terms of mortality rates. IHS much worse than the rest of the nation. Unfortunately, where I'm from in the Great Plains, even worse than the aggregated data from Indian Health Service. One of our big challenges and one of the big social determinants is poverty. And we can't think of poverty just in terms of income. Of course, we have lower incomes. But we also historically never had a concept of land ownership. And when we think about wealth in terms of modern times, much of that is based on owning land and owning homes. But we were never of the mind that we would own the earth. We don't own our mother. And if you think about that whole concept, the earth's been here billions of years. In the sliver of an instant that is my lifetime, I believe I can own it, and then the earth will be here for billions more years. That's a silly concept from a traditional perspective. So we have to recognize that our cultural ways of understanding are very different in many ways compared to modern belief systems. So we have very few American Indian people left relative to the rest of the population. You can see there are 7 states that have at least 3% American Indian population: Alaska, Arizona, New Mexico, Oklahoma, North Dakota, South Dakota, and Montana. So was it always this way? Did we primarily always live in the West? Historically, did Indians not like the East Coast? Is that the issue? Well, no. So when we're looking at the social context, we also have to understand the historical context. And the 13 colonies were not good for the northeastern tribes. There were many vibrant communities and tribes in that area. You may have heard of Amherst, Massachusetts, and Amherst College, named after Lord Jeffrey Amherst. And he's famous in Indian country because he is the one who ordered the distribution of blankets from a smallpox hospital with the purpose of wiping out the northeastern tribes. And you can Google Amherst smallpox and actually see the letters that were written back and forth. And I like how the word Google is now a verb, where we can actually look these things up. The Trail of Tears, I'm sure many of you have heard of. In this process, many of the tribes in the southeast were moved to what is now Oklahoma. And in that process, quite often the tribal populations were split apart. Some people stayed in their homeland and some moved to Oklahoma. So that's why we have Seminoles in Florida, Seminoles in Oklahoma, Cherokees in North Carolina, Cherokees in Oklahoma, Choctaws in Mississippi, Choctaws in Oklahoma, because of that relocation program. Discovery of gold was not good for the California tribes, and ultimately what we are left with is relatively small population. So when we think of social determinants of health, and we also think about the policy impact of having a small population, we now have federally recognized tribes in 35 states. So that means there's 15 states, and therefore 30% of the Senate doesn't have tribes in their constituencies. Do they care about our issues? Will it help them get reelected to invest in Indian country? Well, absolutely not. So we have to recognize part of the social determinants of health is based on that history and the fact that we have a smaller population. One of the things that's not very well described in appropriate terms is the fact that we did face a near genocide here in the United States and in the Americas. It's estimated that there are about 20 million indigenous people in North America and South America, and about 5 million of those were in what is now the United States. By 1900, that number got to less than 200,000. So almost a complete genocide. And we need to recognize it in those terms. These are not easy things to talk about or think about, but it is the truth. And we will never get to equity unless we go through truth, even if it's uncomfortable. So we have to recognize these things. The good news is the 2010 census, 5.2 million self-identified American Indians. So we have made a recovery. So we hear a lot about historical trauma and what has happened to our people, and I appreciated the brief discussion this morning on epigenetics. I think that the field of epigenetics will provide the scientific platform to try to understand historical trauma. And we know that stress can have an impact on the way genes express proteins and then how they work. So we can actually see a genetic impact from stressors. Also, what's unique to American Indian history is the boarding schools. My own mother is a survivor of the boarding schools. She's nearly 80 years old. She still doesn't like to talk about it. She won't talk about it. And that's just one generation ago. So this isn't just looking at 1492. This is looking at the generation of my own parents and the boarding school experiences in which many of our children were taken thousands of miles away had a huge impact on health outcomes today. This is a picture from the Carlisle Indian School in Pennsylvania. And next to many of our boarding schools, there's huge graveyards. And each one of those headstones represents an American Indian child between age 6 and 12. Why were so many American Indian kids dying at boarding school? We know that there were outbreaks of tuberculosis, but that doesn't answer the entire picture. And I also think about the survivors. What is the impact on the children when you see so many of your friends and classmates dying at boarding school? So we've had terrible impact just from these types of policy events. In addition, just looking at exposure to different types of food. Now, the WIC program, Women, Infants, and Children through USDA, that's improved a lot over the last 10 to 15 years. But when I was working as a full-time primary care doctor, the WIC program on the reservation was basically a baby formula distribution center. They were just handing out formula. So we had the highest rates of formula feeding, and that correlates directly with higher rates of diabetes. So it's improved now, but there's been many generations of damage already done. The FDPIR is the Food Distribution Program on Indian Reservations, the commodity food program, and we know the outcomes of commodity foods. And ironically, when we think of traditional American Indian food, a lot of people think of fry bread, right? We never fried dough. That's not indigenous food. It's people doing the best they can with their commodities. You can see the elder has the blue bag of flour. That's a commodity flour, making fry bread. So if you want to call it traditional food, call it traditional USDA food, not traditional indigenous food. Then the whole field of adverse childhood experiences, and I apologize I have to go through this so quickly, but I'm sure many of you are familiar with the ACE study, Adverse Childhood Experiences. And what that study shows is that the more adverse experiences someone has in childhood, the worse their health status is as an adult. And we see changes in neurodevelopment, social development, and then ultimately early onset of disease, disability, and death. And when I look at the things that are correlated with adverse childhood experiences, things like obesity, diabetes, depression, suicide, heart disease, smoking, alcoholism, drug abuse, those are basically our disparities, aren't they? So as we're working further upstream, we cannot forget the connectivity between the health of our adults and adverse childhood experiences, and we need to work further upstream. Unfortunately, we also have toxic stress in many of our communities, and there's an emerging science looking at toxic stress. But in many ways, those are adverse adulthood experiences. Living in a community immersed in poverty and substance abuse is a highly stressful way to live, even if we don't recognize it as such in a formal way. But that then has an impact on the next generation. Children who suffered through adverse experiences become parents eventually, and does it have an impact on their parenting skills? So as we're talking about the whole field of nutrition and access to healthy foods, we have to put it in the right social context. And we have to recognize that we have a lot of other barriers in Indian country. It's not just about access to healthy food. We need to address a whole gamut of challenges in the social arena. So our challenges, of course, poverty, unresolved trauma, political challenges, inattention and neglect to our issues. Is racism still alive and well? I think if you look at some of the blog posts just about the Standing Rock issue and the pipeline, it's remarkable how overt the racism is today. Not 100 years ago, today. So the outcomes, again, terrible disparities and inequities in health, education, and poverty. So we need to address these issues in a comprehensive way, medically, behavioral health, and public health. We need a public health approach to food sovereignty. And we need to recognize that there are reasons why our populations are suffering so much from poverty and less access. So that's a very quick overview of some of the challenges that we're facing across generations. But I did want to go through that quickly because my good friend and colleague Olivia is doing just remarkable work with the Notah Begay III Foundation, and wanted to give her a chance to talk for about 15 minutes, and we'll have time for Q&A after that. So please join me in welcoming Olivia Roanhorse.
That was incredible, you guys. You do realize he teaches North Dakota State, and all of those components are different courses over semesters. So, I mean, that was awesome. Well, I wanted to first say thank you. I'm really excited to be up here co-presenting with Dr. Warne, new friend, now longtime friend. I am Dene. I'm originally from Wind Rock, Arizona. I am near to Water Clan, born for Bitter Water Clan. My grandfather on my mother's side is Water's Edge, and my grandfather on my father's side is Red House Towering Clan. So I don't know if I have any relatives out there, but I'm happy to be here and present to you. So I'm glad he did all this cool statistics and graphs. I don't have any of those. But that's what makes this a really good, I think, right? I'm already telling myself it's good, presentation mix for us. I work at the Notah Begay III Foundation. We are a Native-controlled nonprofit focused on addressing Native children's health around obesity prevention and type 2 diabetes. We are, unfortunately, as far as I know, the only Native-led nonprofit doing this work nationally. One day I want someone to raise their hand and say, that is not true, Olivia. We're here too. So I have two goals for my presentation today. The first is I want to share about our approaches at the foundation when it comes to the social determinants of health. How are we approaching this issue? Why are we approaching this issue? And what are we doing around the Indigenous perspective and thinking about the social determinants of health? And then it's very specific to children's health, so just stay with me there. And the second thing is beginning to discuss what factors affect food choices in our communities and how they all relate to some form of the social determinants of health. I think I have like 7 slides, so be wowed. For those of you who don't know anything about the foundation, really quick, we were first started in 2005 by Notah Begay III. Our mission is pretty straightforward, but incredibly complex in thinking about the strategies. We partner with tribal communities and Native nonprofits across the country to do this work. We have 2 major programs. MB3 Fit is more of our local Southwest program that's on the ground, curriculum development with youth, access to sport through golf, cross country, as well as soccer. So the vehicle doesn't matter. It's about getting kids engaged in moving, nutrition, education, leadership. Native Strong is our national program that we launched in 2012. Thanks to funding through Robert Wood Johnson Foundation, the Kellogg Foundation, and to Shakopee. We reinvest a big chunk of those dollars into Native communities working on the ground to address childhood obesity the way that they want to do it. And we support them through the direct grants, but also capacity building and other ways. I like to start with this slide because it reminds me that the questions, the perceptions of how we're doing this work is really about how we, as Native and Indigenous people, define what is healthy and well, right? We all have our conceptions. We've all learned through school or public health. What does that mean? And oftentimes it's siloed and compartmentalized when it comes to Western education. We put them in blocks. We put them in areas so that we can make sense of them. But we as Indigenous and Native people we never did that. It was bigger. It was part of something greater that we always knew that we had to recognize: land, spiritual, mental, physical. So that's the space that we're thinking of this thing, which makes it even more complex. But why not, right? Like, the world is complex. You can't simplify things. Oh, and that was from our conference last year where we had some folks put up in their language, what does that mean to them? And oftentimes I notice that it's usually just 1 or 2 words, and then in English we're like, health is, and we're still going on and on. So it's just an interesting perspective to have. So what we did is we did some research, and we looked at what out there from an Indigenous perspective has been done, what has been written around the social determinants of health. And what was missing in the conversation when, the World Health Organization was talking about it, you got Healthy People 2020, where was the Indigenous perspective in these conversations? And what was unique to Native and Indigenous communities that weren't part of what we call the determinants, the things that we're looking at that we're trying to measure and incorporate? So this was one of the papers we found, and it pretty much says there wasn't anything out there that included the Indigenous perspective in the social determinants of health. We looked at First Nations papers, Aboriginal Australian papers. Unfortunately, there isn't a lot in the United States, but I'm pretty sure I might have among colleagues who might know of some really good readings. I know the CDC has done some good work on this perspective as well. Let's see. So the part of, I think, what Dr. Warne talks about so well is that the circumstances and systems that we've grown up in, where we work and live and play, have evolved over hundreds of years. And those systems, destructive and others that we've had to kind of build our resilience and build our protective factors, are the things that we know we've seen over generations. Talking about fry bread not being an Indigenous food. Well, you don't just change behavior and perceptions in one generation. It takes time. It takes conversations and discussions about what does it mean to be healthy in your language and who you are. And we want to have those conversations in a way that the community is ready for and wants to discuss. So what we did is we created a framework. And it's a really long, I won't read it to you, framework. And this took the existing written literature out there to explain why we took this approach around social determinants of health. What was missing? What were the opportunities and the strengths that we knew communities already had? Kind of that discussion of, sure, we can look at graduation rates, but let's also look at all the other things. If it's a technical school, if it's a trade school, what are the positive things that we know our communities are already engaged in? And let's include those in these discussions, right? So we did it. It's more of a broad framework of research, but we wanted to get a sense of what are the root causes, what are the differences, and then also eventually we're going to be collecting, based on the indicators that we've outlined, we're going to go to 5 states and look at what type of publicly available data sets are out there when it comes to these indicators. The Indigenous indicators, which make them unique because they're not really listed anywhere, was this importance of access to and utilization of traditional lands. We know that we're deeply connected to the land, that the land is not just something we own, and so that's that feeling of, are you in your Indigenous land? What did that land mean to you and your ancestors? And how does that have an impact on your health? Well, it has a great impact on your health. The same thing with historical and generational trauma. We know through boarding schools, we know through displacement and reallocation and assimilation. I always do this exercise when I talk about, think about, where you were born and where you grew and the foods you ate. Where did that food come from? And then I said, now pretend to put yourself in your grandparents' shoes, right? And have them try to think, where did they get their food from? Where did they grow it? Where did they buy it? And there's a huge generation gap just from our grandparents and our great-grandparents to where we are now. So how do we have those dialogues and conversations that is inclusive of all of those things? So, looking out there in research, this was one of the few models that we came across that really stood strong to our core values of how we do our work. So this was from Reading and Wayne. They did some work with First Nations, among others. But it's the idea that when and where we grow up is important, but also the life course perspective, from preconception to pregnancy to early childhood. We knew those things were important. Not researchers like the first 5 years of brain development is really important and could shape the rest of your life. Adverse childhood experiences. We knew that when we were in our communities. We knew children were sacred. We knew that pregnancy was an important part of building our family and communities. So this was the one way we could start to look at life course, and then, of course, the colors, mental, physical, emotional, spiritual health, all part of a life course description, and then within the social determinants of health, right? I probably didn't give that justice, but this did later. So here were our indicators. So, what are we measuring? What does all that mean? So we picked a few to begin with, because you got to start somewhere. And these are not inclusive of everything by any means. This is just a start for us to start to think about what are some of those determinants that have an impact on our health, good and bad, challenging and opportunistic, right? So that was our first, and this is based on, increasing physical activity and healthy nutrition, not just nutrition. So we're looking at it broader. Oh, so this is cool. I had our graphic designer do this. So it's the only cool slide I have. Don't get too excited. So these are, what are the factors that affect our food choice? I'm not a dietitian, although I think that would be a second professional degree for me. But what is it that when we're thinking about eating our food or buying our food, what it comes into play? There's lots of things, right? And this is just the beginning. There's lots. So there's the social constraints, right? Are we working day to day? Do we work 80-hour weeks or 40-hour weeks? That has, something quick. We want to buy it, short. And then also, what is taste preference, right? Biologically, we're all about, it's hunger, so we got to eat. But there's so much more when we're choosing our food. And there are components of it that, based on when I used to live with my sister, she's an amazing cook, I probably gained 10 pounds because she was putting butter in everything, and I loved it. Don't get me wrong. There's something socially inclined about sitting together, eating, talking about it. So those are all things, and we know that communities who eat the same food when you're the child in that family, you're not going to say, I'm not eating that because it doesn't have anything green in it. You eat what you're given, right? And then, of course, there's the physical aspects, the things that are surrounding us that tell us what's available and what's not. Being a food desert or food insecurity, however you want to call it, that has an impact on our health and what we choose to buy or not buy if it's a convenience store. But there are also opportunities in that, right? I think there's a lot of great work that's happening that says on the other end of that, more people are starting to grow their own food. I just started my first garden, and I'm still trying to figure out, when do you harvest stuff? I'm Googling everything. And then, of course, there's money and time. Those are, big things. And then psychologically, over time, what did we eat when we were very little that resembles home, right? It probably was fried bread. I think of fried bread and the smell, and I can see my grandmother making it in the kitchen. You can't change memories quickly like that. There's taste, there's palatability. You got to think of the things and the stressors over time that get us to what's that last thing I'm going to eat at the end of the day, right? And last but certainly not least, and I think this is incredibly profound for, I think, Indigenous communities, is the role of culture and language and meal preparation, how you pick what you pick, why you pick what you pick, right? And those stories around those things when you grow your own food, that an incredible power when I tell them to my daughter. She's more willing to eat something green if I tell her the story and she's watched it grown than if I said, put some, frozen peas or corn on the side. All right, I'm going to end up with just sharing that, our Native communities are unique and distinct in their own right through languages and culture and land and how they're providing access and food to their communities. These are a few of our communities from across the country. So we've given out over 60 grants to 60 communities, 2.4 million to date, because we know that the communities are working on these things the way that they want to work on them. So here's a few more. These are my favorite pictures. Why wouldn't you want to share some pictures, right? Mm-hmm. And that's it. That's my presentation. So thank you for this time, and we'll gladly take some questions.